Welcome to the deep dive. Today we're getting right into hemophilia, really crucial stuff for your pediatric revision. We've gone through the sources, pulled out the key info, aiming for that, high-yield understanding you need.
Yep, let's get you up to speed.
Think of it as your focused guide to really nailing this condition.
Okay, so hemophilia. At its core, it's a rare genetic disorder. Basically, the blood doesn't clot the way it should.
Right, because something's missing.
Exactly. There's a deficiency, or maybe the clotting protein itself is defective. We're talking factor VIII for hemophilia A.
A for 8.
You got it. And factor IX for hemophilia B.
B for 9. Okay.
And the direct result of that is excessive bleeding. It could be from an injury, maybe surgery, or sometimes just spontaneously.
And it's mostly inherited, runs in families.
Primarily, yes. And it almost exclusively affects males, which we'll get into.
Okay, so let's just make sure we've got A and B clear. Hemophilia A, that's factor VIII deficiency.
Correct. And it's the more common type globally, maybe up to 1 in 5,000 males.
And hemophilia B.
That's the factor IX issue. Less common, maybe around 1 in 20,000 males.
A is 8, B is 9. That little mnemonic helps.
Definitely. Oh, and there's a specific subtype worth mentioning briefly, hemophilia B laden.
Laden. What's special about that?
Well, it has this interesting pattern where the bleeding tendency can actually change, sometimes improve as the person gets older, particularly after puberty. It's a bit unusual.
Huh. Interesting detail. Worth keeping in the back of the mind. Okay, so what actually causes this? The etiology.
It boils down to inherited mutations in the genes responsible for making those clotting factors.
So a fault in the instructions, basically.
Precisely. The body just can't produce enough functioning factor VIII or factor IX because of that genetic change.
Which leads us to risk factors. Who's most likely to get this?
The number one risk factor is definitely family history. If hemophilia runs in the family, the risk is higher.
And that links back to the genetics, the inheritance pattern.
Yes, it's X-linked recessive. That's key to understanding why males are primarily affected.
Okay, break that down for us. X-linked recessive.
Right. So the genes for factor VIII and IX are on the X chromosome. Males have one X and one Y chromosome. If their single X chromosome carries that faulty gene...
They're like hemophilia.
Exactly. Females, on the other hand, have two X chromosomes. So if one X has the faulty gene, the other X chromosome usually has a normal copy, which can often compensate.
So they don't usually get hemophilia themselves, but they can carry the gene.
Correct. They're typically carriers. They can pass that faulty X chromosome on to their children. Each son of a female carrier has a 50% chance of inheriting the faulty gene and having hemophilia.
Okay, that X-linked pattern is really fundamental. So let's talk pathophysiology. What's actually going wrong in the clotting process?
Well, the fundamental problem is just inadequate blood clotting. You don't have enough working factor VIII or IX.
Right.
So when there's bleeding, the whole clotting cascade, that sequence of reactions needed to form a stable clot, gets interrupted.
Like those dominoes we talked about. One is missing or wobbly.
Exactly like that. That specific factor isn't there to do its job, so the process stalls, and you don't form a strong, stable fibrin clot quickly enough.
Which leads to that prolonged bleeding, or even spontaneous bleeds.
Precisely. Bleeding that goes on for longer than expected, or happens without an obvious injury.
Makes sense. Now, if someone comes in with unusual bleeding, hemophilia is on the list, but what else should we be thinking about, the differential diagnoses?
Good question. Top of the list is often von Willebrand disease. It's another inherited bleeding disorder, quite common actually, but it involves a different protein von Willebrand factor.
Which does what again?
It helps platelets stick together, and it also acts as a carrier for factor VIII. So problems there can cause bleeding too.
Okay, so von Willebrand disease. What else?
You've got other, much rarer, inherited bleeding disorders affecting different clotting factors. Then there are acquired conditions.
Like things caused by liver disease or certain medications.
Exactly, acquired coagulation defects. And finally, don't forget platelet disorders where the number of platelets might be low or the platelets themselves just aren't functioning properly.
So quite a few possibilities. Getting the diagnosis right involves careful history and specific tests.
Absolutely crucial. You need those lab tests to pinpoint the exact problem.
Right, and how common is hemophilia here in the UK? The epidemiology.
In the UK, if you combine hemophilia A and B, the prevalence is roughly somewhere between 1 in 5,000 and 1 in 10,000 males.
So not super common, but definitely something you need to be able to recognize.
For sure.
Okay, so we know what it is, the causes, the risks, the other possibilities. How does it actually look? What are the clinical features?
Let's split it into symptoms, what the patient or family reports, and signs, what we might find.
Okay, symptoms first.
Big ones are prolonged bleeding after injuries, even minor ones, or after surgery or dental work. Easy bruising is common too. And of course, spontaneous bleeding.
Like nosebleeds or bleeding into joints or muscles without any clear reason?
Exactly. Which leads us nicely into the signs, especially the musculoskeletal ones.
Limmerthosis, bleeding into joints.
That's the hallmark, really. You'll see or feel pain and swelling in a joint, often knees, elbows, ankles. The joint might feel warm, look red, or erythematous.
And the patient won't want to move it.
Right. Reduced range of motion is a key sign. Think about that toddler who suddenly stops wanting to walk or bend their knee.
Classic picture. Does the timing of diagnosis give us clues?
It often does. Severe hemophilia usually gets picked up early, often in the first year of life.
How?
Maybe prolonged bleeding from the heel prick test newborns get, or after circumcision if that's performed. Sometimes, unfortunately, the first sign can be a serious bleed, like an intracranial hemorrhage in a newborn.
Wow. What would that look like?
Symptoms might be subtle, like unusual sleepiness, hypoactivity, poor feeding, irritability, or even seizures.
So you need a high index of suspicion in newborns with those signs.
Definitely. Milder or moderate cases, though, they might slip through until later childhood or even adulthood. Maybe diagnosis only happens after a significant injury or planned surgery reveals the bleeding tendency.
Okay. Any other ways it can show up?
Yeah, you can get mucocutaneous bleeding, like frequent, hard-to-stop nosebleeds or bleeding on the gums. And we mentioned intracranial bleeding, a risk at any age, and very serious.
Right. Oh, and fatigue can be a factor, too.
Because of anemia.
Exactly. Chronic or significant bleeds can lead to iron deficiency anemia. And one more point, female carriers. While they usually don't have severe hemophilia, they might still have bleeding issues.
Like what?
Things like menorrhagia, really heavy periods, or more bleeding than expected after surgery or childbirth. So it's important not to completely dismiss bleeding symptoms in known or potential carriers.
Good point. Okay, that covers the presentation really well. So we suspect hemophilia. How do we confirm it? What investigations do we order? The key tests look at the clotting factors and the clotting pathways. So number one is measuring the actual clotting factor levels, Factor VIII activity for Haemophilia A, Factor IX activity for Haemophilia B.
That gives you the definitive diagnosis and severity.
Yes. But screening tests are usually done first. The APT, activated partial thromboplastin time, is typically prolonged in hemophilia.
Why is that?
Because the APTT assesses the intrinsic and common pathways of coagulation, which include factors VIII and IX, so if they're low, the APTT time gets longer.
Okay, so prolonged APT is a clue. What about other screening tests?
The PT, or prothrombin time, is usually normal. It assesses a different pathway, the extrinsic and common pathways involving factors like 7X, which aren't affected in hemophilia A or B. The fibrinogen level is usually normal too.
So prolonged APTT, normal PT, normal fibrinogen, that pattern really points towards hemophilia.
It strongly suggests it, yes. Then you move on to the specific factor assays to confirm which type and how severe it is, mild, moderate, or severe, based on the percentage of normal factor activity.
Got it. Anything else?
Genetic testing can be done to identify the specific mutation causing the hemophilia. This can be useful for genetic counseling, predicting severity sometimes, and testing other family members.
And can you test before birth?
Yes. If the mother is a known carrier, prenatal diagnosis is possible using methods like chorionic villus sampling, CVS, or sometimes fetal blood sampling, though that carries more risk.
Okay, comprehensive testing. So let's say we have the diagnosis confirmed. How do we manage hemophilia?
The absolute cornerstone is factor replacement therapy, giving back the missing clotting factor.
How is that done?
Usually through intravenous infusions of concentrated Factor VIII or Factor IX. There are two main approaches, on-demand and prophylactic.
Okay, what's the difference?
On-demand treatment means giving the factor infusion only when a bleed occurs to stop it. This is more common for mild or maybe moderate hemophilia.
And prophylactic.
Prophylaxis means giving regular factor infusions maybe several times a week before bleeding happens to prevent bleeds, especially spontaneous ones in joints and muscles.
That sounds like the ideal, especially for severe cases.
Absolutely. Prophylaxis is the standard of care for severe hemophilia now. It dramatically reduces bleeding frequency, protects joints from long-term damage, and allows for a much more normal, active life. It's often a lifelong commitment, though.
Makes sense. You mentioned inhibitors earlier.
Yes, that's a significant challenge. Some patients, particularly those with severe hemophilia, can develop antibodies inhibitors against the replacement factor they receive.
So the treatment stops working as well.
Exactly. It neutralizes the infused factor, so regular testing for inhibitors is really important.
And if someone develops inhibitors, is there anything we can do?
It's complex. For severe hemophilia A with inhibitors, there's a treatment called immune tolerance induction, or ITI.
What does that involve?
Basically, it involves giving very frequent, often high doses of Factor VIII over a long period, months, even years, trying to teach the immune system to tolerate the factor again. It doesn't always work, but it can be successful. There are also other agents, bypassing agents, that can be used to help clotting in patients with inhibitors.
Okay. Beyond factor replacement, what else is important in management?
Physiotherapy is key. Strengthening muscles around the joints helps protect them. Maintaining a healthy weight and staying physically active, within safe limits, obviously, is really encouraged.
Any surgical options?
If joints become badly damaged despite treatment, yes. Procedures like synovectomy, removing the inflamed joint lining, or eventually joint replacement surgery might be needed.
And what about the person in the family? It sounds like a lot to deal with.
Definitely. Psychosocial support is vital. Living with a chronic condition like hemophilia impacts the patient and the whole family. Access to support groups, counselors, and social workers is important. And genetic counseling is crucial for families, helping them understand the inheritance patterns and options for future family planning.
So a real multidisciplinary team approach.
Essential for good care.
Okay. With all this management, what's the general outlook? The prognosis?
With modern treatment, especially prophylaxis, the prognosis has improved dramatically. Most people with hemophilia receiving good care can expect to live relatively normal, active lives with a near-normal life expectancy.
That's great news. But are there still risks, especially for severe cases?
Yes. Despite improvements, there's still an increased risk of long-term complications, particularly joint damage in those with severe hemophilia, even with prophylaxis sometimes.
Which brings us to complications. What are the main ones to be aware of?
The big one we keep coming back to is that chronic joint disease, or hemophilic arthropathy. Repeated bleeds into the same joints cause inflammation, cartilage damage, and eventually can lead to deformity, chronic pain, and loss of function.
Primarily knees, elbows, ankles.
Those are the most commonly affected joints, yeah. And then there are the more acute, serious complications.
Like bleeding where?
Bleeding into vital organs is always a concern, and the most feared is probably intracranial hemorrhage bleeding inside the skull. It's less common now with prophylaxis, but it can still happen, especially after head trauma, and it's potentially life-threatening or can cause long-term disability. Inhibitor development is also a major complication of treatment itself.
Okay, so minimizing bleeds through treatment is key to preventing both the chronic joint issues and the acute serious bleeds.
Absolutely. Early diagnosis, consistent treatment, usually prophylaxis for severe cases, and careful monitoring, that's the recipe for the best possible outcome.
This has been a fantastic run-through of hemophilia. We've covered the definition that inherited clotting factor deficiency,
Factor VIII for A, Factor IX for B.
the X-linked inheritance, how it presents, especially that hemarthrosis,
Right, the joint bleeds.
the key investigations like APTT and factor assays, and the management centering on factor replacement.
Both on-demand and prophylactic approaches, plus managing inhibitors and the supportive care needed.
For everyone listening and revising, really lock down those core concepts. Understanding the why, the genetics, and pathophysiology helps make sense of the clinical features in management.
Definitely. And remember those differentials, too. Always keep von Willebrand disease and other possibilities in mind when you encounter bleeding symptoms.
Perfect. Well, if this deep dive has been useful for your MSRA prep, don't forget to check out PassTheMSRA.com.
And for more free resources, head over to freemsra.com.
Loads of helpful stuff there. Thanks so much for joining us today.
My pleasure. Good luck with the revision.